Gavin asked me to speak about intravenous fibrinogen and the REPLACE study. I'm just going to carefully look around the audience as to who's here. I will give you a flavour of some of the REPLACE results. I am unable to give you the full set of results, and even really, apart from a comment near the end, give you an idea of what's happened in the trial. I will take you through a little bit of the history of how the trial developed and why people have been thinking about using fibrinogen. I clearly have some conflicts of interest. I am a paid steering committee member of the REPLACE study, and I've been paid to be on advisory boards for both CSL Behring and Opta Pharma. So, we have a lot of fibrinogen. When you're sitting here, we have an overwhelming amount of fibrinogen circulating as one of our predominant coagulation enzymes. But when we're either subjected to surgery or trauma, it rapidly disappears. So this is the historic HIPALA data, which everybody talks about. It's quite an interesting paper if you go back and review it. So they were talking about critical levels of fibrinogen and various other coagulation enzymes. And at that time, back in the mid-90s, it was thought that the critical level of fibrinogen should be about 1. And many of us have challenged that since, and David's already talked about pushing it up to 1.5 to 2, and we've heard other people speaking about that today. What they did in this study is people undergoing general surgery, and as they lost blood, their blood was replaced just with packed red blood cells. And they tracked their coagulation enzyme levels regularly. They were monitoring them. And then at the point in time when the team started giving other constituents or other blood products, they stopped tracking, but they then extrapolated the data to say, well, what amount of blood loss will be required before you hit the critical levels that assumed a sort of 1 gram per litre or 20% of your prothrombin. And what is interesting is you don't need to lose a lot of blood, 142% compared to the other coagulation enzymes. So you're going to downgrade your fibrinogen much more quickly than anything else. This is more up-to-date data from Herbert Scholl's group in Austria with patients who were traumatized. And they looked at their fibrinogen levels on the y-axis versus their hemoglobin, their base excess, and their injury severity score. And if you're in green or yellow, when you hit the door of the emergency room, your fibrinogen levels are either adequate in green or okay in yellow, they're going down. But in red, you've gone way below what they consider to be a normal fibrinogen level. And it looks like about 2/3, 50% to 2/3 of their trauma population, as they hit the door in the emergency department, these are bloods that were taken straight away, had a fibrinogen level that they considered to be critically low. We know from data that David showed us, more recent data that Kayvan produced, but we can look at George Despace's data, which came out in the mid-90s. Patients undergoing cardiac surgery, coagulation proteins measured, patients who didn't bleed, patients who did bleed, decreased percentage. And if we look at fibrinogen here, those patients who were on bypass a lot longer and did bleed had a greater than 60% reduction in their fibrinogen at the time of their surgery. So we know you've got a lot of fibrinogen around. We know that it disappears very quickly when you're traumatized or when you're having major surgery, and we know that cardiopulmonary bypass reduces your fibrinogen very rapidly. The question is, actually, is fibrinogen that important? And there is there's some animal data, and there's some in vitro data. And this is the in vitro data by Thomas Lang. Here on the y-axis you have clot strength, and here you have platelet count. So if we look at sort of a platelet count of 200, for instance, and the blood is then spiked with to give you different levels of fibrinogen, you can see as your fibrinogen level increases for the same platelet count, your clot strength increases. So that would suggest that you're able to form a firmer, stronger clot, which is clearly what we want in somebody who's either bleeding or oozing a bit. If you magnify this area where your platelet count is low, and you see it in here, and each stepwise is from black to grey to white is the highest level of fibrinogen, we see that you have a greater clot strength even at very, very low platelet counts. So this is some evidence that perhaps fibrinogen is very important in how you form clot and firm up your clot, and perhaps reduce your bleeding. So why have I picked this slide? This takes me back to a number of years ago, and it was the sort of thought processes that a number of you be having about fibrinogen concentrate. So recombinant 7A, essentially, if you think about how the hypothesis of it worked initially in haemophiliacs, it's known as a bypassing agent, because it bypasses this stage of the coagulation process, because this stage doesn't happen if you can't have factors 8 and 9. And this is the theory of how 7A works, and it's a bypassing agent leading to a large generation of thrombin. What a number of us felt was that perhaps fibrinogen, given the issues we've seen with 7A, particularly thrombotic issues we've seen with 7A, could play a key role as a single agent. Because many of us have been looking for a single agent we could give that would reduce the complexity of transfusion in complex, unwell patients and allowing them to have a better outcome. Now, fibrinogen concentrates have been around a long time. They've been licensed in Europe for over 30 years for patients with hyperfibrinogenemia, and in that group of patients, they are relatively safe. There's a very, very good database collated for patients and their thrombotic sequelae who've been given reasonably large doses of fibrinogen concentrates, and the amount of thrombotic incidents that occur is very, very small. However, despite that, there has always and historically been an issue around the quite high fibrinogen levels, and is it a mediator or marker of vascular disease? And that predominantly came from myocardial infarction work done in the 70s, where it was noticed that patients who presented to hospital with myocardial infarction had markedly raised fibrinogen levels, and this was felt that either it contributed to you having a myocardial infarction, or it was just a marker of your vascular disease. There's more recent animal work, so you can genetically change mice to overexpress fibrinogen, and they've been shown not to have an increased risk of atherosclerotic disease. There are a number of humans who have a polymorphic change in their fibrinogen gene and hence overexpress the amount of fibrinogen, and again, when they've been followed up, they don't appear to be at risk of myocardial infarction. So there is maybe some evidence that fibrinogen is safe in patients who don't have hyperfibrinogenemia, but still we're not there with the safety data. Well, what can you get bang for buck, not money-wise, by giving fibrinogen concentrate in yellow as opposed to cryo or FFP? So here you have the dose of fibrinogen or cryo FFP. This is a patient with a very, very low fibrinogen. So if you wanted to take this patient from 0.5, okay, up to fibrinogen of 1.5, you would need to give 4 grams of fibrinogen. That's equivalent to about 16 units or 3 packs of cryo or 20 units of FFP. So if you give fibrinogen concentrate, it's not small volume, 4 grams is 200 mils, okay, it's about 50 mils per gram, maybe 100 mils per gram. It's a while since I've made some up. But you're going to get considerably less volume than certainly FFP, or potentially less donor exposure in addition. Where did the story with fibrinogen all start in cardiac surgery? Well, this is the original publication of Niels' data in very small numbers, retrospective observational data, allogeneic blood products given to either 12 or fibrinogen concentrate given to 6 patients undergoing thoracoabdominal surgery. Now, one of the things that's always struck me about the Hanover data is we don't do thoracoabdominal surgery at 34 degrees. Okay? It just doesn't happen in my centre. They all go down to 16 degrees. So they're doing a different operation from what I'm doing, or what's been put in front of me. And this is true for the data that David just showed you, that if you look, the one thing that struck me was they're not cooling down. So they're just doing isolated descending thoracic aneurysms on partial left heart bypass. They're not doing open, open top ends, which is what we tend to be doing. However, having said that, in a small observational data set, they were able to show a marked reduction in any patient's requiring transfusion of any allogenates after their surgery, and it was quite marked, and it was an interesting finding. This is another way of presenting the data that David just presented. So this is thoracic aortic aneurysms. Actually, these were ascending aneurysms, so they weren't abdominal aneurysms. And here you have those patients in red who got fibrinogen concentrate, and in blue who did not get fibrinogen concentrate. So a larger retrospective study, not in descending thoracic aortas, but in ascending aortic aneurysms with arches. And you can see a marked reduction in packed red blood cell use, in FFP use, platelet use. Clearly they're all getting fibrinogen concentrates. And you're talking about a difference of 13.9 units, a median difference of 13.9 units of transfusion, which was really quite a remarkable finding at the time. So Niels went on and developed a RCT with support of CSL bearing. It was a 61 patient randomized trial in a single centre that has a very, very good surgeon that really only does major complex aortic work. It doesn't do a lot of other types of surgery. I put that in parentheses now because this is clearly becoming obvious as I get towards what happened in Replace. That maybe going into a multi-centre trial doesn't work quite so well with multiple surgeons, multiple anaesthetic teams and ICUs working. What did they do? You had your surgery. They calculated a dose of fibrinogen to give you based on an MCF, and then you finished bypass, you reversed your heparin with protamine, and they then assessed microvascular bleeding, and basically by using swabs or packs, if you fell between 60 to 250 grams packing of hemoglobin on your swabs within 5 minutes, you then either got fibrinogen concentrate or placebo, and then you got packed again. No more bleeding, or less than 60 grams, end of surgery, more bleeding, you went into a standardised transfusion regime receiving platelets or FFP. So this is a 61 patient RCT in a single centre. Published in Anaesthesiology last year, patients in fibrinogen concentrate group in red, in placebo are in blue. Median number of units, 13 versus 2 for all patients. Okay, that's a marked reduction in a single centre. If you break it into the different types of surgery, this is thoracic abdominal aortic aneurysms. These are thoracic ascending aortic aneurysms with the arch and without the arch, and again you see major reductions in all of them. As this trial went on and was really being finished, and they were looking at the preliminary data, a group of us got together with CSL to set up what was known as the Replace study, which started recruiting in January 2012, finished recruiting in August 2015. Top line results have been available since about November 2014. The objective of the study was to assess the efficacy of fibrinogen concentrate treatment controlling microvascular bleeding during complex surgery. The primary outcome was the number of allogeneic transfusions you had within 24 hours after you either given fibrinogen concentrate or placebo. This is the type of flow that happened in the surgery. So these patients were having major complex aortic surgery. So you could be having a root replacement, you could be having a root with an arch or hemiarch, you could be having a thoracic abdominal aortic aneurysm. That could be just here, or it could be an open top end. So really quite complex patients. We changed the protocol about a third of the way through to include patients who'd had previous surgery, reduced stenotomies, providing that the aortic arch wasn't being redone or the aortic site wasn't being redone, but if you'd had previous grafts or previous valve, you could be included in the surgery. Again, we calculated the dose of fibrinogen using a FibTem. You finished your bypass, you reversed your heparin with protamine, you made sure the patient was warm, they weren't acidotic, you did a 5-minute bleeding mass, and I'll just whip through what that is in a second. And then if you fell into either the 60 to 250 gram sort of bandwidth, i.e. you were bleeding enough to get in but not too much, okay, You then got your fibrinogen or your placebo, and then there was a standardised treatment regime for if your bleeding mass continued to be greater than 60, or even when you got into the ICU, and the primary endpoint was measured by the number of allergeneics you saw within 24 hours. 152 patients were thought to power the trial, with 76 in both arms, and this was a commercially sponsored trial. So what do I mean by a 5-minute bleeding mass? Now, to me, I know that people have said they can't get their surgeons to pack, but actually it's part of what we tend to do anyway. It's just an objective measure of bleeding in the operating room. And I agree it's sort of a little bit difficult, but you make sure your heparin's reversed. The interesting thing, and I think I've spoken with David about this, is that I think this was taken to be a mark of surgical honour in this trial. That actually the first thing we asked people to get was surgical hemostasis, so make sure you didn't have any obvious bleeding. Surgical teams were allowed to use topical hemostatic agents they wanted to. They then suctioned the field clear, and then they packed. And we just told them to wait 5 minutes. And it's sort of part, if I give a coagulation talk to the Royal College of Surgeons and talk about surgeons, I tell them that there are lots of P's involved in coagulation, and they stand for packing, proline, patience, and pressure. And that actually stops quite a lot of bleeding without any complex tests, without any complex coagulation agents being required. And I think actually this does a lot, and that stops a lot of bleeding. You take the swabs out, you weigh them, and if they've got between 60 and 250 grams, you get you've been randomized before, you then actually get into the trial. What was the transfusion regime? Okay, so your bleeding mass is positive. It's greater than 60 grams, it's less than 250. Okay, so less than 60 grams, you fall out, no treatment. It's greater than 60 grams, less than 250, yes. Your platelet count's less than 100. You knew that because we did an end of bypass platelet count. You get 1 unit of platelets. You do another bleeding mass. Greater than 60 grams, you get 4 units of FFP. Do another bleeding mass. Greater than 60 grams, you get 2 units of FFP or 1 unit of platelets. Okay, the other way around, you get a bleeding mass between 60 and 250. Yes, your platelet count's greater than 100, you start with 4 units of FFP. Another bleeding mass is greater than 60, you get 1 unit of platelets. Another bleeding mass is greater than 60, you get 2 units of FFP, 1 unit of platelets. You do another bleeding mass, it's greater than 60, and believe you me, there were patients who had 5, 6, 7, 8 bleeding masses in this study. You then revert round this little cycle here, getting 2 units of FFP and 1 unit of platelets until your bleeding mass is less than 60 grams, at which point you get closed up and you get taken to the ICU. Bring you back to this slide here. And the reason for this is that when this study, which really mimics the Hanover study, very, very closely, okay, was first put up, my sort of view was, oh, it's interesting. I wonder what we're actually trying to look at here. Are we trying to look at the effect of packing? You know, because although everybody's going to get packed, but were we investigating whether packing was what was good for you? Were we investigating whether it was fibrinogen and placebo? Those are the two differences. Or were we actually investigating a transfusion algorithm? And I was never particularly clear on that. And it's one of the things that with transfusion trials that's become obvious to me with time, that actually there are a range of things that you can be investigating, particularly when you throw in a transfusion algorithm or set of tests that drive you through a transfusion algorithm. You can never be certain what it is the intervention that is actually really changing. Everybody had a fairly standardised procedure in the ICU. So you hit the ICU, if you lose greater than 300 mils in an hour, or part thereof, 150 mils in 30 minutes was the minimum, you would be given 1 unit of platelets or 2 units of FFP, which was relatively simple for a post-operative algorithm, particularly that concerns the one that I developed for the 7A trial. Now, this is where I can show you a little bit of the data. I have to be quite careful about what I can show you, but I'll ask very specifically not to show too much data, because this trial is being presented at the European Society of Anesthesiology meeting at the end of May, start of June. But I didn't think this was breaking too much information out. This was the disposition of patients. So we ended up screening 579 patients. 60 were screen failures, didn't meet the criteria. They randomized 239 patients into the concentrate group, or 280 in the placebo group. I've never had this relatively reasonably answered to me, actually, even though I'm on the steering committee. My view is that once you're randomised, that is your intention to treat group. Okay? That is what we should have been looking at. But they felt it wasn't, and actually they called that, once you got into the study, once you either got concentrate or placebo, that was their intention to treat group. Well, I actually feel that once you randomise anybody in a clinical trial, that is your intention to treat group. So how did you fall out of here? Because clearly we've got big numbers here and much smaller numbers here. Well, when you look at what fell out, across both sides, it was failed intraoperative criteria on both sides. Okay? Now, you could fail the intraoperative criteria by having a bleeding mass of less than 60 grams or greater than 250 grams. Okay? Very, very, very few patients failed to get into the study because they were bleeding more than 250 grams. It's something like 95% of patients didn't get into the study because they were bleeding less than 50 grams, less than 60 grams. Now, when we originally asked centres to give us some idea as to what their transfusion requirements were for major aortic surgery, and after a poll of the audience here, how many would say would transfuse 50% of patients who had a thoracic abdominal aneurysm? Hands up?
At least 50.
Okay, that's pretty much what every centre said. How many units would transfuse at least 50% of patients who had a root with an aortic arch? 50%, okay. How about just a root replacement? We think probably maybe 20–30% of our root replacements might get transfused. But everybody sort of said those were the numbers, okay? Would it be interesting to find out that all these patients fell out of this study because they just didn't bleed? They got packed and they didn't bleed and they didn't get transfused. Okay, and they fell out. What the most fascinating thing is that the roots bled, an isolated root bled way more. There were more roots that got into the study than roots and arches. People who went on to circle respiratory, root and arch, very rarely got into the study. I mean, it confounded everything that most of us thought we would see in practice. But there you go, that's clinical trials for you. These patients then got into the study and they then completed the study. I'm able to show you this. Where did we get the patients from? Japan. There was a lot of concern when CSL said they wanted to go into Japan. The patient population is very different there. The surgical approach is very different there. Their bypass times make the North American bypass times look very short, and North America makes UK bypass times look very short. Okay, I mean, you know, Japan will take what we do in 2 hours and extend it out to about 6 hours. That's fine, their outcomes are very good. Interestingly, the outcomes from the Japanese patients were excellent, okay, despite the fact they were very long. The United Kingdom, across mainly Papworth and Southampton, Leicester and Liverpool, contributed 24 patients. Canada, mainly your centre, Dave, isn't it, contributed 21 patients. The Czech Republic were very good, and there was a number of smaller European countries that were pulled together to get 20 patients because that was how they were analysed. This is my last slide, and it's really the only thing I can tell you about the study, is the results were unexpected. They did, I am allowed to say that they did not meet their primary outcome. Okay? You can ask me some questions on that if you want, and I might be able to say more. But that is all I'm allowed to say, which is really, really surprising both for the company and for all of us that were involved in the study. It was quite a surprise. One of the things I've taken away from this is that actually when you look back at how fibrinogen concentrate has been used successfully, France has used it very successfully both in observation data sets and in an RCT, it has always been used in combination with other transfusion packages, particularly PCCs. And it might be that fibrinogen as a single agent isn't quite as effective as some of us hoped it would be. Thank you very much.